As this inaugural edition of 1969, Audio Digest presents a special report from the just concluded American Medical Association 22nd Clinical Convention in Miami Beach, as we look at massive upper gastrointestinal hemorrhage and peptic ulcer disease, the surgical point of view. Participants in this program, Volume 16, Number 1, include the University of Miami's John J. Farrell, Yale University's Douglas A. Farmer, the Medical College of Alabama's Frank G. Moody, the Leahy Clinic's Kenneth W. Warren. And to begin, here is Dr. Farrell, who serves as program moderator.
The first speaker is Dr. Farmer, and he'll speak on the management of upper gastrointestinal hemorrhage. Doug?
Unfortunately, the criteria for the definition of massive upper GI hemorrhage are not the same in the opinion of all workers. There are several different definitions. All of them are valid, but for the purposes of comparing results in different series, it's a shame that the same definition isn't used in all cases. These are all good criteria and all valid. 1, shock, not syncope, but real shock. 2, a reduction of circulating red cell mass to 60% or less than normal. That is to say, less than 18 cc's of circulating red cells per kilogram of body weight. Hematemesis plus the passage of reddish stools, not melena, but hematemesis plus the passage of reddish stools. Hemoglobin less than 8 grams and hematocrit less than 30 in face of acute bleeding. And finally, the need for 1,000 cc's or more of blood to restore the volume to normal. Now, the emergency management is something familiar to most of you. I would stress the importance of the team approach. When the person is seen in the emergency room, he should be seen by a medical man and a surgeon at the same time, and they should follow him together through the course of his illness. Fluids, of course, are given rapidly at first, and the initial fluids are usually saline or a balanced salt such as a Ringer's lactate. Dextran, preferably Dextran 70, I think, is a better plasma expander. Whole blood, of course, as soon as possible is the mainstay. This should be given in large quantities and rapidly, and if possible, a fresh blood to restore coagulation factors should be given every 3rd or 4th transfusion. Oxygen is given if necessary, if the patient's been in shock and exhibits air hunger. And of particular value is a rapid passage of a nasogastric tube. Particularly if the person hasn't had hematemesis, it's vital to know whether there's blood in the stomach on admission to the hospital. Also, the tube can be used therapeutically with interval irrigation of iced Maalox and saline mixture, and the tube can be kept on suction, which gives information regarding rate of bleeding, whether the bleeding is stopped or not, and finally, it also removes acid and pepsin from the gastric contents. The vital signs are kept track of frequently. If there's a question about shock or impending shock, the tilt test is a good one. Namely, the head of the patient's bed can be elevated 30 to 60 degrees, and the patient can be observed for about 3 minutes. If he exhibits signs of restlessness, pallor, sweating, or if his pulse goes up and his blood pressure goes down significantly, shock is probably impending and the fluid therapy has not been vigorous enough. I will mention pressor drugs only to say that they're probably contraindicated. I refer to aramine, Levophed, and so forth. The patient is maximally vasoconstricted generally under these circumstances due to spontaneous catecholamine output, and there is no need for the further use of Levophed. It only decreases further tissue perfusion by increasing vasoconstriction and is termed by some an embalming fluid. Except under the most unusual circumstances, what are the most likely diagnoses? The esophageal varices are the commonest of the group in the esophagus bleeders. An ulcer slightly less common. The Mallory-Weiss laceration also less common. The bulk of the problems will be either the acute or chronic ulcer in the stomach or duodenum with gastritis, erosions, and tumor following along. There are other diagnostic considerations. These are the more unusual, the more bizarre causes, the blood dyscrasias, such as blood malignancies, acute or acquired thrombocytopenic purpura, the coagulation defect that goes with liver disease, including the patients on anticoagulants, and there are more of those now with the prevalence of heart replacement and the post-coronary treatment with anticoagulants. All of these should be thought of, and these should be screened by immediate complete blood count, smear for platelets, bleeding, clotting, and prothrombin time. Diverticularly, both in the duodenum and jejunum, can bleed. Duodenal, very, very rarely. Jejunal, perhaps considerably more frequently. The various vascular malformations should be kept in mind. By these I would refer to congenital telangiectasia, the Osler-Weber-Rondeau disease, multiple phlebectasias, hemangiomas, and so forth. Even small aneurysms of branches of the gastric artery have ruptured and have caused massive upper gastrointestinal hemorrhages. Cholecystoduodenal fistula will rarely bleed, and another man-made cause, aorticoduodenal fistula in patients who have had an aneurysm resected and the upper anastomosis between the aorta and the graft is not protected from the duodenum. Leakage occurs and massive bleeding can occur. Uremia, it should be borne in mind that always the bleeding from uremia is not just a uremic enterocolitis. There can be a discrete lesion, and if so, it should be dealt with as a discrete lesion. The diagnostic techniques, which should have been going on during the emergency therapy, are as follows. Blood should be drawn, of course, for the hemoglobin hematocrit and at intervals thereafter. Also the white count, to look for the usual increase in white count, which occurs with GI bleeding, but a decrease in leukopenia will promptly lead one to suspect that an enlarged spleen is playing a part in the clinical picture. Bleeding, clotting, and prothrombin time, the smear for platelets, the BUN, the sugar, which can be increased early in shock, as you know, electrolytes, and very important, a BSP. A BSP retention of greater than 15% suggests liver disease. And as a matter of fact, over 90% of cirrhotics who come into the hospital bleeding will have a BSP retention of greater than 15%. This procedure should not be done while the patient is still in a state of shock, however. History and physical examination naturally is a very important tool. Try to get a history of peptic ulcer disease, but bear in mind that in 10% of peptic ulcer patients, hemorrhage may be the first symptom. A history of alcoholism or hepatitis or schistosomiasis would lead one to suspect varices. History of bleeding tendencies and the blood dyscrasia is important to look for. Recent ingestion of alcohol or drugs such as aspirin, steroids, anticoagulants, Wolfia, and so forth is important. And also a history of malignancy or previous operation in the stomach, which would lead one to suspect a stomal ulcer. Important in the diagnosis of the Mallory-Weiss syndrome is the order of occurrence of the vomiting and the bleeding. If the vomiting and retching comes first, followed by bleeding, one should suspect a laceration of the esophagogastric mucosa. Very important is to try and detect history of other underlying disease, namely hypertension, cardiovascular disease, chronic pulmonary disease, or renal disease. These have a great deal of bearing on the outcome. On physical examination, in the commonest lesion, look for tenderness in the epigastrium, which is very suggestive of an active duodenal ulcer. Look for telangiectasia, particularly around the lips, or purpura, all of which suggest the dyscrasias. An abdominal mass can be sought for, and of course the signs of cirrhosis, hepatosplenomegaly, liver palm, spider angiomata, ascites, and an abdominal venous pattern. As far as the introduction of the tube, I've mentioned the therapeutic aspects, but it has diagnostic aspects. This can be put down and aspirated at selective levels, namely the lower esophagus, in the stomach. And if no blood is found in the stomach, it means either that the bleeding is stopped or that the site of bleeding is below the pylorus, coming, of course, from the duodenum or the upper small bowel. Some massively bleeding ulcers don't regurgitate blood back through the pylorus, while at the same time, occasionally people with massive bleeding from the fourth portion of the duodenum, such as the aortico-duodenal fistula or a massively bleeding upper jejunal diverticulum, will show blood regurgitating back through the duodenum and into the stomach. Melena can occur with lesions as low as a Meckel's, or as in a case reported by Bacchus, in a carcinoma of the ascending colon. As far as other emergency procedures, I think an emergency GI series is a very vital part of the workup. There's a disagreement about its value, but it can be done with the patient still bleeding. It can be done only, of course, after the patient has been stabilized, but it should be considered an emergency, and it will show up in many cases chronic gastric or duodenal ulcers, hiatus hernia, and tumors. It'll also show large varices of the stomach or esophagus, but may miss the small varices. It's not of much use in gastritis and acute ulcers and erosions of the stomach, the minute ulcers. Esophagoscopy is the best diagnostic tool for bleeding varices and for Mallory-Weiss syndrome. However, it shouldn't be used in the emergency situation if there's no blood in the stomach or found by tube. Unfortunately, it requires the presence of an expert, and it also requires an anesthesia. About the same might be said for gastroscopy. It shouldn't be done if there's no blood in the stomach, but in the face of negative x-rays, it may be of value to show gastritis or erosions or even small gastric ulcers. Again, an expert is required. Statistically, with a bleeder now, the odds are heavily in favor of the problem of being either a bleeding duodenal or gastric ulcer, so my next few remarks will deal with this situation. In a moment, I'll talk about gastritis and esophageal varices. First, a few generalizations can be made at the outset about massive upper GI hemorrhage from ulcer. The age has a very profound effect on mortality, either in medically or surgically treated patients. It's not so much the age, but it's the complicating illnesses that go with age that lend the increased risk to this group of patients. Now, a few more generalizations. Gastric ulcers bleed more frequently and have a higher mortality rate than duodenal ulcer patients. The chronic ulcers with a heavy callus are less likely to stop. Severe pain accompanying the onset of bleeding usually means deep penetration and less tendency to stop. Hemorrhage in the face of pyloric obstruction is apt to continue to bleed rather than stop. And finally, prolonged blood replacement and watchful waiting in the presence of continued hemorrhage contributes very heavily to a fatal outcome. There are three general philosophies regarding the treatment of bleeding peptic ulcer. First, the conservative or non-operative method, epitomized by the Muhlengott approach. In the final paragraph of his classic work in his article in the Annals of Internal Medicine in 1947, however, he accurately outlined the attitude of those who favor a more aggressive approach, and I quote, "If in the future I should consider the advisability of operation, it shall be, as seen from the perusal of my fatal cases, in instances in which the patient is more than 40 years of age, has persistent or repeated bleeding, manifesting itself as hematemesis, and threatens to die in spite of repeated blood transfusions. There should be no serious contraindications to operation. The presence of an ulcer should have been proved rentgenologically, and a good surgeon should be available." In sharp contrast to the conservative approach is that of Dr. Stewart in Buffalo, namely to operate on all comers, regardless of age or condition, if they meet the following requirements. Gross bleeding into the upper GI tract within a week, measured total red cell mass of less than 60% of normal, and a reasonably good clinical evidence for the diagnosis of peptic ulcer. This may sound radical, but his results support his approach. As of 1965, after 18 years of experience with some 450 patients, a third of his cases were under 50 and the mortality was 3%. Two-thirds were over 50 and the mortality was 20%. This is remarkable in view of the fact that all of the operations were subtotal gastrectomies and all in massive bleeders. This, of course, stops bleeding immediately, it avoids multiple transfusions, and it provides a very definitive ulcer operation. The third method is the selective approach, with which I agree myself. That is to say, operate under one or more of the following conditions: inability to stabilize vital signs with 1,500 cc's of blood in the first 24-hour period, or in the face of recurrent bleeding after an adequate medical treatment in the hospital, and finally, the need for 1,000 to 1,500 cc's of blood daily to maintain stability. I incline more myself towards the 1,000 cc figure. It's difficult to show that the results, however, are statistically improved over those with immediate surgery in all cases. However, I feel that the selective approach avoids some unnecessary surgery in the younger individuals. It emphasizes the importance of the rate of bleeding, but I feel strongly that the factors initial shock, the older age group, and particularly the presence of concurrent disease should push one towards a more aggressive approach. As for type of operation, one shouldn't have a rigid attitude about it. There's little question in the older, very seriously ill individuals, the mortality rate with pyloroplasty, vagotomy, and suture ligation of the ulcer is lower. But in the younger individuals who are in good shape and without too dangerous a situation in the region of the duodenum, I personally would prefer a distal gastric resection and vagotomy with suture of the bleeding point. In gastric ulcers, I would prefer excision of the ulcer and closure of the defect with vagus and pyloroplasty. In the case of acute hemorrhagic gastritis, there's no clinical picture that's classical. This often occurs after a bout of heavy alcoholic intake or after excessive aspirin use. The diagnosis may or may not have been made preoperatively by gastroscopy, or it may have to be made at operation. The pathology is either a patchy or a diffuse area of reddening and edema with adherent secretions, often with superficial erosions and frequently with submucosal hemorrhages. And microscopically, there's interstitial inflammation with damage to the gastric glands, particularly in the neck area, with necrobiosis and sloughing. And this accounts for the erosions that are seen. Bartlett, on the basis of an analysis of 44 cases at the MGH, suggested that if bleeding exceeds 1,000 cc's a day, the chances for spontaneous cessation are poor. Subtotal gastrectomies in the past has been the procedure of choice, but on occasions persistent bleeding from the remnant has resulted in death or has occasioned total gastrectomy. In all probability, vagotomy, pyloroplasty, and oversuture of the bleeding point is the procedure of choice. Now, in the last moment, I'll just say a word or two about the stickiest problem of them all, namely the bleeding esophageal varices. I would say in addition to the usual treatment, one should use posterior pituitary extract vasopressin in doses of 20 units in 100 cc given IV over a course of 10 minutes. This should be repeated every 4 hours. If the diagnosis is known and if this treatment is started and if bleeding continues for more than 4 to 6 hours, I think then a tube, a Senstocken tube, should be placed. And if the bleeding is not controlled by these means in 24 hours, I believe an emergency portocable shunt should be carried out. There is no evidence that the transesophageal ligation of the bleeding varices carries with it a lower immediate mortality rate, and certainly the prolonged survival rate is far lower in the ligation group as compared with the shunt group.
The next presentation will be by Dr. Frank Moody, and he'll discuss some of the latest concepts in the surgical management of peptic ulcer.
The threat of peptic ulcer to man's comfort and survival appears to be increasing in spite of expanding knowledge and spectacular medical breakthroughs. Treatment of this disease, in fact, continues to be based upon the simple, empiric observation that peptic ulcer does not occur in the absence of gastric acid. It's well known that gastric acidity cannot always be effectively controlled by medical means alone. I plan to review the current status and rationale for the surgical approach to this problem. This is a fortunate time for such a discussion, since surgery has evolved into a safe and effective means for controlling the advanced manifestations of this disease. Operative therapy for duodenal ulcer is usually reserved for those patients who develop either life-threatening complications or incapacitating symptoms. Even today, approximately 15% of patients with duodenal ulcer ultimately fall into this category. Definitive operations, regardless of the nature of the complication requiring surgery, must not only salvage life, but also provide permanent relief from ulcer symptoms. Clinical experience has shown that reduction in acid secretion is an essential feature for successful surgical therapy. Vagotomy has been generally accepted as the primary surgical modality for reducing acid secretion. Controversy still exists as to whether vagotomy must be coupled with removal of the gastric antrum to ensure reasonable protection against recurrence, or whether in fact vagotomy accompanied by gastric drainage is sufficient in this regard. There can be no doubt what a finite recurrence rate in the range of about 5 to 20% accompanies this latter procedure, while the addition of distal gastrectomy to vagotomy provides nearly maximum protection against subsequent ulcer disease. As regards the question of who should have operative therapy, I share Dr. Priestley's concept that indications for surgery must be individualized. I'll try to support my own preference for early intervention in the disease by emphasizing the relative safety and effectiveness of surgical therapy. The fact that elective operations for peptic ulcer can be accomplished with negligible mortality has been well documented at the University Hospital of the University of Alabama Medical Center, where there were no deaths following 137 consecutive elective operations for duodenal ulcer during the 5-year period 1963 through 1967. And this is comparable to the experience of others around the country with much larger series. It should be noted with pride in our system for training surgeons that 60% of these operations were performed by the resident staff under faculty supervision. This experience, furthermore, points out that age itself should not preclude operative therapy when indications for surgery exist. And I might say this probably goes for gallbladder disease also. Since 20% of the patients in this series were over the age of 70, it can be concluded from this study that elective surgery for peptic ulcer can be accomplished without mortality when performed by well-trained surgeons. Now, this is not the case, however, when massive hemorrhage requires an emergency operative procedure. It's been pointed out by Dr. Farmer. There were 13 postoperative deaths in 88 consecutive patients operated upon for this complication during a comparable period at the University Hospital. Determinants of mortality under these conditions appeared related for the most part to the systemic effects of massive hemorrhage and transfusion, age, associated illness, and the technical problems of dealing with the ulcer site. 11 of these operative deaths followed resection of the stomach. More recently, we have employed pyloroplasty and vagotomy with deep ligature of the bleeding point within the ulcer crater as the simplest and quickest way to control hemorrhage in such patients. The question of whether vagotomy and pyloroplasty will afford long-term protection from recurrent ulcer disease seems of secondary importance to me when confronted with this serious complication. There has been much discussion about early recurrent hemorrhage following this procedure, but the incidence of rebleeding appears to be quite low in the hands of those who perform this operation with great precision and care. If distal gastrectomy with vagotomy provides maximum protection against recurrent ulcer, why then can it be employed safely in the patient with massive hemorrhage? The answer to this question resides in the fact that patients with acute hemorrhage often have an ulcer deeply penetrating into the posterior aspect of the duodenum. It is, in fact, this location of the ulcer which leads to massive hemorrhage. Resection of the stomach in this instance requires transection of the duodenum through an area of scar and inflammation. Subsequent healing of the remaining distal end of the duodenum is compromised by the presence of bile and pancreatic juice. Surgeons have devised many ingenious methods for protecting such tenuous duodenal closures. There are those who believe that pyloroplasty and vagotomy is in fact an ideal operation for all of the complications of peptic ulcer disease. While I am enthusiastic for this approach in the patient with massive hemorrhage who requires emergency surgery, especially the elderly patient, I reserve its use for rather specific indications in the ulcer patient who is to undergo elective operation. In this latter patient, I am most concerned with permanent cure, which clearly can best be accomplished by antrectomy and vagotomy. For example, the patient who comes to operation for intractable pain is an ideal candidate for this approach. It is equally well suited for the patient with recurrent episodes of bleeding when operated upon electively, since a favorable site for transecting the duodenum is usually encountered. I never hesitate, however, to employ vagotomy and drainage when I encounter a difficult or anticipate a difficult duodenal dissection. The risk of recurrence in this situation is much preferred to a life-threatening postoperative complication. A prime consideration in this operative approach is removal of the gastric antrum, which is known to be the major source of gastrin in man. This can be accomplished by actual mapping of the non-secretory area of the lower end of the stomach with pH-sensitive paper. In practice, however, it is fairly well accepted that the antrum will be encompassed in the majority of cases when the lower half of the stomach has been removed. I prefer to reestablish gastrointestinal continuity by joining the gastric remnant to the duodenum as a gastroduodenostomy whenever possible, thereby avoiding the complications which may follow a gastrojejunostomy, such as torsion, internal hernia, afferent loop syndrome, bile reflux gastritis, and a host of other rare but distressing sequelae. Gastric drainage and vagotomy is an ideal elective procedure in cases with advanced age or severe associated illness, since it provides adequate protection against recurrence under these circumstances. This is also a desirable operation for long-standing chronic obstruction when this complication is accompanied by marked debility. I also favor pyloroplasty and vagotomy as a definitive approach to the patient who manifests an acute perforation following a long-standing history of ulcer disease, since this procedure can be done with safety under these conditions. Several groups have demonstrated that resectional surgery can also be accomplished with a low mortality rate in this population. Simple plication should be employed when perforation is the sole manifestation of ulcer disease, since it's known from experience that this patient may have no further ulcer symptoms following recovery. This procedure is also desirable when surgical therapy of a perforated ulcer has been delayed beyond several hours. The side effects or late sequelae of gastric surgery, such as dumping, small capacity syndrome, weight loss, anemia, and osteoporosis, have all been well documented. It's generally agreed that post-gastrectomy symptoms are directly related in their severity to the amount of stomach removed. Consequently, most surgeons now avoid extensive resections for duodenal ulcer disease. Pyloroplasty and vagotomy is also accompanied, however, by unpleasant side effects which are less frequent and severe than those which accompany gastric resection. In fact, the extragastric effects of vagotomy are not fully known. Selective vagotomy, wherein only the vagus innervation of the stomach is interrupted, has been advocated in order to avoid diarrhea, the most prominent symptom of truncal vagotomy. While this procedure is attractive in theory, it has not gained widespread acceptance since truncal vagotomy is a less complicated procedure. Advocates of selective vagotomy emphasize that this is the best way to ensure vagal denervation of the stomach, and possibly this consideration will represent the greatest advantage of this approach.
Excuse me, Dr. Moody. Long enough to say that this, doctor, is the end of this side of your reel. On side B, Dr. Moody continues his discussion of the latest concepts in the surgical management of peptic ulcer disease. And to hear this, simply reverse the 2 reels or cassette cartridge on your tape recorder. B, Audio Digest Surgery, Volume 16, Number 1, an issue devoted to massive upper gastrointestinal hemorrhage and peptic ulcer disease, the surgical point of view. Now, continuing his discussion of the latest concepts in the surgical management of peptic ulcer disease, here once again is Dr. Frank Moody.
The surgical treatment of gastric ulcer deserves special consideration, since it appears to be quite a different disease than duodenal ulcer. While massive hemorrhage, obstruction, and even perforation do complicate gastric ulcers, these are less frequent than the symptoms of abdominal pain or disturbances in nutrition, at least in my own experience. A further consideration is the possibility that gastric ulcer may be a manifestation of carcinoma. The latter has assumed less importance as an indication for surgery, with improved methods of radiologic, endoscopic, and cytologic diagnosis. The primary indication for operative treatment of gastric ulcer at the present time is failure to heal on medical therapy. The most popular form of operative therapy consists of removing the ulcer and the lower portion of the stomach within which it resides, and in fact, which I continue to carry out in my own practice. This approach can be carried out simply and safely in the majority of patients, since gastric ulcers usually occur in the lower portion of the stomach. There is evidence, however, that a gastric ulcer will heal when the acid secretory capacity is reduced by vagotomy and pyloroplasty. Multiple biopsies of the ulcer is taken in order to eliminate the possibility of cancer. I reserve this approach, however, for those patients who present with high-lying gastric ulcers, which are technically difficult to remove by limited resection of the stomach. Multiple superficial gastric erosions or stress ulcers remain a difficult therapeutic challenge. This disease often occurs in the setting of massive physical or thermal trauma, overwhelming infection, or extensive operative stress. While vagotomy and pyloroplasty has been employed successfully In a few such cases in our hospital, the incidence of rebleeding and ultimate mortality is high. Extensive gastric resection in such patients is also associated with a high mortality and failure rate. If at operation we can identify a single erosion which has penetrated a large vessel, then we prefer to excise the erosion and perform a pyloroplasty and vagotomy. When erosions involve the distal half of the stomach, then a partial gastrectomy with vagotomy is considered to be the preferred operation. Multiple diffuse erosive gastritis of the proximal stomach remains a surgical enigma. I personally believe that it is best to do a vagotomy and pyloroplasty in this disease and make an attempt to suture the predominant areas of bleeding. It is generally conceded that we do not as yet have an adequate surgical approach to this entity. We presently strive for early identification of patients who might develop this syndrome and treat them vigorously with antacid therapy, either orally or through a nasogastric tube. When gastric ulcer is found in association with duodenal ulcer disease, it is essential to employ the principles of duodenal ulcer surgery if an operative approach is required. It is well established that recurrence after distal gastrectomy for gastric ulcer is rare, except when there's a history or evidence of chronic duodenal ulcer. Furthermore, an ulcer which occurs within the caloric antrum while gastric in location has the physiologic features of a duodenal ulcer and should be treated as such. My own preference is to advise surgery fairly early in the course of this form of ulcer disease. Will the present conservative trend in the operative approach to peptic ulcer continue? The answer to this question resides in the ultimate incidence of recurrence which will accrue from drainage and vagotomy. An additional factor of increasing importance as we strive for perfection in this area of surgery relates to the late sequelae of vagotomy. Bruce, and more recently others, have advocated the use of selective surgery based upon the level of gastric acid secretion. Their objective is to employ a limited gastric resection in low secretors in order to avoid the side effects of vagotomy or extensive resection. The preliminary results suggest that it is feasible to tailor gastric surgery in this way, but there is still insufficient experience to accept this approach with a high degree of confidence. The key to success of selective surgery lies in the ability to accurately assess gastric secretion with a high degree of confidence. Gastric analysis is most helpful to me in the identification of hypersecretors, and I obtain it on all patients who are to undergo gastric surgery for peptic ulcer disease. I have found the 1-hour basal and the maximal histamine stimulation test of K to be simple and reliable in this regard. It is especially important to identify patients with the Zollinger-Ellison syndrome, since to overlook such individuals can lead to a disastrous surgical result. It's my opinion that such patients should have a total gastrectomy when positively identified by near maximal basal secretion of acid. The cure of this disease by excision of a solitary adenoma in the pancreas or even by vagotomy and antrectomy appears to be an unusual clinical event. On the contrary, excision of a parathyroid adenoma will invariably relieve the ulcer diathesis of hyperparathyroidism. There are many facets to the surgical treatment of peptic ulcer disease. I have attempted to relate a simple and safe clinical approach which is in step with the times. In my opinion, the priorities for selection of an ulcer operation are, in order, safety, effectiveness, and the absence of unpleasant side effects. It would seem that future progress in this area will depend on developing better ways for matching the procedure to the patient. As in all areas of clinical medicine, the ultimate solution resides in a complete understanding of the disease, a reality which at this point in time appears to be in the very distant future. It's comforting to know, however, that the recalcitrant ulcer can be managed safely by operative means with a remarkably low recurrence rate within the framework of our present surgical expertise.
Now, Dr. Kenneth Warren joins Drs. Farmer and Moody in answering some questions generated by their discussions. Our program moderator, Dr. Farrell, poses this initial query.
I suppose that you don't have the facilities that Dr. Farmer said relative to being able to carry out angiography, so on. You just have your routine measures such as a nasogastric tube, which often happens when you get in. How do you start out to find the bleeder? What do you do, Doug?
I depend on the very long gastrotomy and careful irrigation with saline of the stomach, careful packing with dry, clean gauze, and, if necessary, division along greater curvature so that you can evert through your gastrotomy the gastric mucosa using a sponge on a stick. And in most cases, you probably will be able to find that little area tucked down between some gastric folds and determine the point of bleeding. Failing that, I favor the, quote, blind, but it's really not blind, gastrectomy, rather than closing and doing nothing.
When you say a long gastrotomy, that means you aren't transecting the pylorus at that point?
No, I would start my gastrotomy above the pylorus and feel down into the duodenum first and carry on up into the stomach. If I couldn't feel anything in the duodenum, I would then feel constrained to open and look. And I'd probably convert it into a pyloroplasty later if I were going to suture ligate some vessel up in the stomach.
How'd you convert that long gastrotomy?
I'd close most of it and then probably do a thinny rather than trying to mess around with a hinocomiculates pyloroplasty under these circumstances.
Dr. Moody?
Well, we use one other adjunct, I guess, which sort of flavors my approach, and that's endoscopy, since Dr. Hershowitz happens to be in Birmingham, and they're very active in this regard. And they identify, I guess, about 60% of the bleeding sites that we have in these patients. They do endoscopy very early, almost as soon as they hit the emergency room, followed by GI series. So we're very aggressive in terms of evaluating these patients. Therefore, at surgery, we usually know where the site of bleeding is. I must say, I usually make my incision right through the pylorus, with the idea that I'll be doing a pyloroplasty. And one other thing that I do is I stick my finger up into the lower end of the esophagus, because occasionally there's a little hemangioma sitting up there that you can feel, or even a tear that you can't see, that you can then feel inside the stomach.
And you have a fairly long gastrostomy, too, to get your
No, I use a low and a high, and then I evert almost the whole stomach through this high gastrostomy.
And your high, what do you do? Is it just another longitudinal?
Yes, just no longitudinal.
Incidentally, speaking of endoscopy, I think one of the most valuable endoscopic stunts is to have them boil up a sigmoidoscope for you when you're looking around and to look at the cardioesophageal junction. It's one of the best ways I know of to see a Mallory-Weiss slit or an esophageal ulceration that's bleeding.
Ken?
Well, yes, I would agree with most of what has been said. First of all, though, I would cochorize the duodenum in the head of the pancreas, because I think you can feel a posterior penetrating ulcer better after that. I also would agree with Dr. Moody that I would go through the pylorus, because I think this is the most likely, percentage-wise, everything else. So that's about the way I go about it. Obviously, I'd look for other areas of ZE, tumor, or something of that sort. In general, if you have the time, I do just the opposite. I explore every other possibility before I explore the duodenum or do a gastrotomy.
I'd like to make a pitch for, instead of making a longitudinal gastrostomy higher up, make a transverse one. Make it about 2 finger breadths or so below the junction. You can see practically the entire stomach. That plus a modest gastroduodenotomy. Yes, Ken?
I wonder if the members of the panel will express themselves on doing a vagotomy with the so-called blind gastrectomy. Should they be done together?
Yes, I would think so, particularly if you think probably what you've been dealing with is gastritis. I believe there's something in what I mentioned. Dr. Waddell and his group at Colorado are suggesting that the dramatic cessation of bleeding in gastritis may be due to the submucosal AV shunting. And so if you're going to leave a remnant, say, of a half or a third of the stomach, I think you better protect it by doing a vagotomy, because certainly subtotal resections have failed on occasion, and people have had to go back in and remove the remnant and do a total. I think the vagotomy is probably very protective in this.
Now, I just do a fluoroplasty and vagotomy in this instance. I really don't see what the resection adds to this, since you visualize the area and there's no bleeding point there.
I think Dr. Warren mentioned, though, that if you had done a resection for some reason or another, would you add vagotomy or not?
I think in a situation like this, you better do everything that has any prospect of eliminating hemorrhage. In terms of what Doug has said in Dr. Waddell's paper, this is the most dramatic thing I think you see in gastric surgery, where you have massive gastritis and hemorrhage all over. You do a vagotomy, and within 2 or 3 minutes, the character of the mucosa has changed.
As far as elective gastric surgery is concerned, I'd like to have each of you tell the audience exactly what pre-testing you require, say, on a person who is going to get a gastric surgery for duodenal ulcer disease, but on an elective basis, either because of intractability or minor recurrent bleeding episode, any of the usual indications for duodenal ulcer surgery. Doug?
Excluding the diagnostic tests, I think you're referring primarily to the gastric acidity studies. And I've been interested in gastric acidity studies in a great many years, have used both the basal augmented histamine and I think possibly find more useful the basal insulin test. You want to know, particularly if you've got a hypersecretor, a marked hypersecretor, that the response on basal and the response to stimulation are not fairly close to identical, or at least say within 50% of identical, because if that's the case, then you pretty much have to suspect the Zollinger-Ellison syndrome. The thing that I like best about the insulin study is if you're going to do preoperative and interval postoperative studies, particularly if you've been interested in vagotomy for a great many years like I have, the insulin study is a pretty valid test of whether you've accomplished what you set out to do. And also, just on the basis of experience, at least in our laboratory at any rate, on the basis of basal and insulin, it gives you a very sharp definition as to whether you've accomplished your purpose or not. For if on the basis of the basal insulin test, you find that the pH of the gastric contents is above 3.5 under both conditions of study, you can say, ergo, the peptic activity in that stomach is so low as to be clinically negligible, and this patient is completely protected from recurrent ulceration. Now, I don't know any figures that Kay or anyone else has produced, and I think Kay has made the same complaint, which says, on the basis of the augmented histamine study, what is the percent of reduction that is an absolute guarantee. It's a potent stimulus, and if you say, well, you've got to have an achlorhydric from the basal augmented histamine test, you know very well that most of the patients aren't going to be achlorhydric from that point. So I'd like to know, on the basis of the basal augmented histamine, what percent do you want to have reduced them, or what pH level do you shoot at for protection to give you some prognostic idea as to whether or not you've accomplished what you set out to do.
Dr. Moody?
My own feeling is that it's important to get at least a basal secretion, and this can be done most conveniently in the morning. It's important to get the tube in the right place and have the patient as relaxed as possible, and then aspirate a few samples and see if they in fact are hypersecretors. If they are, then I think once you go a step further to see if you can stimulate them.
What do you use as a definition of a hypersecretor?
Oh, I think anyone that is secreting in excess, let's say, of 10 milliequivalents per hour. I like to think in terms of the rate at which hydrogen are being secreted, then I think one should pursue it further in terms of seeing whether in fact this patient also has an enlarged parietal cell mass or secretory propensity. I don't think that the maximal stimulation test contributes very much more, however, other than to show whether the patient is already secreting at a maximal level. If he is, he may well have a ZE syndrome, and one should make this diagnosis before you operate.
Ken, do you want to add anything?
No, I would agree with that. I think in terms of ZE syndrome, this is such a complicated thing that you can dream your own hormones, you can synthesize them, but if you have a patient with such a syndrome, do a total gastrectomy, no matter what else you do.
I don't know whether I agree entirely with that. I've only managed to get one virginal stomach as far as the ZE is concerned. All the rest of them had previously had everything from vagectomy, partial gastrectomy, vagectomy, pyloroplasty, and so on. The virginal one that I got, I left the antrum in. Delineated the difference, which was easy, of course, with dye through a gastrotomy, and I was sure that I had all the acid-secreting portion, and then they just interposed a terminal ileum and cecum and anastomosed it to the antrum and gave them fluoroplasty. As far as management afterwards concerned, I don't think I've ever had a total gastrectomy as benign and everything as this particular patient was. Would you object to that, or
it's a complicated operation, I think. Patients who have total gastrectomies for benign disease get along quite well anyway, no matter how you hook them up.
That's true.
I'm concerned.
Due to fortuitous circumstances, I've added one other test that I require. That's a calcium phosphorus and alkaline phosphatase.
I certainly agree about your calcium studies. I always do that. Dr. Moody mentioned one level of 10 milliequivalents of output of hydrochloric acid per hour. I think it should be emphasized that that's an excessively massive secretion. Admittedly, they'll go on up to 20 or 25, but the average for let's say 500 duodenal ulcers studied by basal, is only about a 2.2 milliequivalent output per hour, 2.2 to 2.5, and then there's a great deal of variation in this basal output. And if you just measure the people who put out, let us say, 10 or more, you'll find that the emphasis on the Zollinger-Ellison syndrome is perhaps overdone, because you'll find around 15 to 20 patients who are just hypersecretors with duodenal ulcer who put out 10 or more milliequivalents to every one Zollinger-Ellison patient who puts out the same amount. Of course, the ulcer patients will respond in kind to stimulus.
Right. When do you start suspecting a ZE, though? See, if you say 5, then you're looking at too many people. If you say 10, then you're starting to narrow down on a population.
I start suspecting it at the same level, 8 or 10.
Dr. Farmer, do you see ZE syndrome with less than a 15 basal?
Are you talking about patients with an entire stomach or patients with half a stomach? I think Ellison's latest suggestion has been that you really start seriously considering it at 15 if they have an entire stomach, and if they're secreting from a gastric remnant, that you start considering it at 5.
Isn't the truth, though, that it has to start sometime? They start with one cell in this tumor secreting gastrin, so therefore at some point they may be just secreting normally.
Right. As you pointed out, it's more the relationship between the basal and the stimulated secretion. If they're maximally secreting on basal and can't get up much higher when they're stimulated, then is the time to really suspect that something is putting out an optimal amount of gastrin.
I think it should be pointed out that some ZE syndrome do not have either hypersecretion or hyperacidity. They have a different hormone. That's why I say dream your hormones. But they have small bowel symptoms rather than ulceration.
Diarrhea and so on, that's right. And hyperirritability, hypermotility.
Malnutrition.
I'd like to ask each one of you, since Dr. Moody gave his preference for an antrectomy, bilateral vagectomy, and a gastroduodenostomy as an elective procedure in most instances, considering age and all that. What do you do, Dr. Farmer?
That's what I do, a distal gastric resection and vagotomy, taking into consideration the mortality rate and the desirability of having a live patient rather than the patient with a good operation if necessary.
Do you do a gastroduodenostomy or gastrojejunectomy?
Generally a Billroth 2, although sometimes a Billroth 1.
Dr. Warren?
Yes, I probably do at least a 50% resection. I think that's just tradition that we've always done, but I think that's the procedure of election.
It's interesting, Dr. Farrell, that 10 years ago we could engender tremendous controversy about what we should and shouldn't do electively for the patient with duodenal ulcer. Is this a sign of the times that we're getting a little stagnant, or have we found the answer?
Well, I don't know. 10 years or so ago, people were much more rigid in doing one type of procedure, where I think now we tend more to tailor the procedure to the individual. For example, by preference, we would prefer to do a gastroduodenostomy over a gastrojejunectomy. But again, as you suggested, if you find that you're going to have to spend a long, tedious time dissecting sufficient duodenum and that it might be a little impaired vascular-wise, I have no hesitancy to switch over to a gastrojejunectomy.
Do you do a vagotomy with yours?
Yes, always. Yes,
I think one problem here in terms of the question Dr. Moody raised is that you asked an elective operation. I think we'd find a lot of controversy about the others.
Well, this is what I was leading up to next. Dr. Farmer, in an emergency gastric surgery for hemorrhage, for example, what do you actually do, Doug?
In the older, poor-risk patient, I'll do a vagotomy, pyroluroplasty, and a suture ligation, knowing it's not as good an operation as the other. In a younger person who I deem a good risk, and if by palpation I think things are going to go along smoothly in the region of the duodenum, I would do a ligation of the vessel, a distal gastric resection, and vagotomy.
Dr. Moody?
Certainly, fluoroplastic vagotomy and deep ligature in the hands of those who do a lot of them as their preferred treatment seems to be quite successful, and we've only recently started a year and a half ago to use this approach, and now at the University Hospital have done some 10 patients with one death, an 88-year-old lady who died of a heart attack on the 10th day, but none of them had rebled. Now, at the VA hospital, which is still part of our system, we've done 8 cases, and we've had 2 that have rebled and had to have gastric resections, and one of those patients died. So I'm a little more equivocal than I said in my talk.
Dr. Warren?
I think my attitude is colored by experience, and we prefer to resect them. I'm sure there's a limited place for ligating the vessel, and I would like to make a point that I ligate the vessel if I use this procedure outside of the duodenum, not in the base of the ulcer, where you will have a better chance of securing the gastroduodenum, both above and below. But I still prefer to resect them, and this is an easy resection in general because they're bleeding posteriorly. They separate easily from the pancreas, and I do a vagotomy, obviously.
Do you ever have any trouble finding that gastroduodenal artery, Ken?
I have trouble with everything I do, but I think you can find the gastroduodenal artery at the junction with the hepatic, especially if you do a lot of pancreatic surgery where you deal with it all the time. And distally, it's usually no problem at all. But I would agree in general, it's a very poor risk. I would also like to emphasize the patient is not so sick that he should not be operated on. He's usually too sick not to be operated upon. You will have internists sit around and tell you why the heart's too bad, the kidney's too bad, the liver's too bad, the lungs are too bad. That's precisely the patient that should be operated upon early, in my judgment.
I feel that the incidence of recurrence, I think it takes a relatively fair number of years, and this is why I've swung over to vagectomy, fluoroplasty, and suture in a goodly portion of my patients, but a goodly portion of my patients are such as, see, up in Lake Worth, adolescence ends at 65, so that we don't do much adolescent surgery. And as a consequence, I find myself doing more and more in the 70 and 80-year-old group, and feel that it's a fairly reasonable procedure at that age group.
I think something should be said about the gastric ulcer. I don't think you should ever leave a gastric ulcer in place. Once the belly is open,
it should be excised.
I think so.
There was a comment about biopsy. Is that what you're referring to?
I'm referring to two things. First of all, I think it's an easy operation. Secondly, 16% of them are malignant, and biopsy is notoriously unreliable. Hazard, the Mayo Clinic likes to scrape them and get a heavy representation of the entire ulcer. I think that's better, but I still would prefer to take it out.
Any comments?
Well, I might just ask, what about the one that's high on the lesser curve close to the esophagus? You excise that, do you?
Yes, sir. I excise that one because after all, you can leave as much of the greater curvature as you want to, very much like you're going to do a total. And you do something very similar to a Schumacher, and you take the ulcer out.
What if this is multiple superficial ulcers with massive bleeding in an elderly patient?
Well, this is where I would do what I think was recommended here. You do a vagotomy, you do a pyloroplasty, and you be sure that you do a good pyloroplasty.
Yes, I have no reluctance to do four-quadrant biopsies of these ulcers that one can see, and usually with endoscopy they can tell you that it's benign, and it always is, really. But there is this 5% where they say you get it in the anatomical pathology room and look at it, and you still can't tell it's a carcinoma, and you do biopsies and you make the diagnosis, but I think you're doing that at surgery, and these ulcers do heal when you do fluoroplasty and vagotomy. I'm talking about a very specific lesion that's penetrating into the pancreas.
Penetrating ulcer.
Doug, do you?
Well, I've been unorthodox about this for the past few years because I felt that if you use a very careful preoperative workup and step-by-step operative procedure and have a good pathologist, the hazard of undiagnosed malignancy has been overdone in gastric ulcer. So I now, as I mentioned in case of the ones without bleeding or the posterior perforating or even the lesser curvatures, I just excise the ulcer, convince myself from looking at it it's benign, ask a pathologist to help me agree, and then just close the defect and do a vagus and pyloroplasty.
But you're still taking the ulcer out.
I'm never satisfied just with four-quadrant biopsy.
Is this electively?
Yeah, this is what I do for gastric ulcers, admittedly. That's what I meant when I said I thought perhaps some of the panel...
That you're now just excising them, doing a vagectomy pyloroplasty.
Yeah.
Are you, Dr. Moody?
No, I'm resecting, because the majority of these are down in the lower half of the stomach, and the high ones, I also, if I can get a good resection on, lesser curve, take them also. But then the one that is penetrating, and I've only had a couple of these, and they've healed, and I think the literature supports the fact, I don't know what you feel about the fellows out in Los Angeles, but they seem to get fairly good results, at least reported results, with their approach with fluoroplasty and vagotomy.
Well, this is interesting, and I think Dr. Farmer knows so much more about it, and I'm sure you do. When they started doing vagotomy, this was for duodenal ulcer. Now they're doing it for gastric ulcer. So I think if you go back to the material that Sam Marshall presented over the years, he had pretty wonderful results with subtotal, but I still think a vagotomy should be added.
I haven't swung over to vagotomy. Fluoroplasty alone with local excision. If it's an elective procedure, I'll go ahead with a gastrectomy on it. Well, I think that I can speak for all the audience that you've done a really fine job of clarifying things that have proved to be problems to all of us, and I hope that I have the opportunity to hear all of you again sometime.
Thank you, gentlemen. And this concludes this inaugural 1969 issue of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation, a non-profit subsidiary of the California Medical Association. All rights are reserved.